Hello, everyone. I hope you're doing well and safe in this pandemic. I'm Dr. Abughoush, and I'm internal medicine resident. Today, I will be doing a talk, a literature review about some of the neurological manifestations of COVID-19 and the case report that I have worked with at the hospital with the neurology team. I'm delighted to be part of this meeting, and I hope you'll find this quite beneficial as well. So I'd like to introduce you to the team. It includes Dr. Mahfoud, he's a consultant neurologist, Dr. Mani Zaabi, consultant neurologist and head of department as well, and Dr. Muhammad Abu Naga, who is a specialist in neurology. So some of the objectives that I would like to discuss today, just a brief introduction about COVID-19, a literature review about the neurological associations of COVID-19. I will present the case that we managed and treated at our hospital. We'll discuss some few points, some interesting aspects about that case as well. A few points at the end for as a conclusion. So as we all know, COVID-19 has now become a world pandemic, and it was initially reported in Wuhan, China, by the end of 2019. In March 2020, it was declared as a pandemic by the WHO. As we all know, the virus is highly contagious, and similar to other coronaviruses, the SARS-CoV-19 virus, it mainly affects the respiratory system, and with time, as the pandemic progressed, we faced some cases that included insult to the neurological system. Patients could present in a wide range of symptoms and in various degrees as well, from mildly symptomatic to severely symptomatic individuals and those who end with acute respiratory distress along with multi-organ failure. My next few slides will be basically based on a rapid review article, which is entitled as The Neurological Manifestations of COVID-19. It was published in the Lancet Neurology journal in July 2020. So as I mentioned earlier, by time we came to know that the COVID-19 not only could it affect the respiratory system, it can also affect the neurological system as well. Multiple cases have been reported of individuals with such manifestations, and until to date, 901 patients have been reported. These manifestations could be as a result of several mechanisms. It could be the direct effect of the virus on the nervous system. It could be para-infectious. It could be post-infectious as a result of the cytokine storm and the immune-mediated response to the COVID-19. And also it could be as a result of a neurologic complication of the systemic effect of COVID-19 virus. In one national registry of 125 patients with COVID-19 who were followed over a 3-week period, 31% had an element of altered mental status. 62% had some sort of cerebrovascular event, half of them being ischemic strokes, and 7% having an intracranial hemorrhage. And the focus of our topic today and our discussion, which is CNS vasculitis, only in 1%. So this would reflect that it's quite a rare condition to have, which is CNS vasculitis. So let's shed some light about the mechanisms involved. So there are two main questions to raise in mind. Firstly, the route of entry of the virus into the nervous system and the relative contribution of the viral infection versus the host response to the subsequent damage caused by the virus. One theory had been proposed that the virus could enter to the brain through the olfactory bulb, which is the only part of the CNS which is not protected by the dura mater, and hence it would be a point of entry for the virus to affect the nervous system. And it could be contributing to the fact that patients with COVID-19, they could have a symptoms such as anosmia. The other concept that I think most people are familiar with is the one related to the ACE receptors, ACE2 in particular. Those receptors, they're found in the vascular endothelium of the brain vessels and the smooth muscles as well. And hence, it can facilitate the entry of the virus into the nervous system as well. Furthermore, damage to the CNS or the peripheral nervous system might be caused directly by the virus itself or by the body's reaction to the virus, whether through the innate or the adaptive immune response. Here is just a simple demonstration of the possible mechanism of the viral entry into the body cells. As you can see, the virus attaches to the ACE receptors and then it gets engulfed into the cells in order to infect them. And those ACE receptors, they're present in various parts of our body, and hence the virus could affect multiple parts in the human body. So moving on to our case presentation. So this patient, he's 66-year-old gentleman. He presented to the emergency with 7-day history of fatigue, fever, and the dry cough as well. His blood work investigation showed raised inflammatory markers with a CRP of 120, and he had an element of lymphopenia as well. On further investigations and imaging, the CT showed peripheral ground glass opacities, which is characteristic of COVID-19 pneumonia. And the diagnosis was also confirmed by the COVID PCR, which was positive for COVID-19. On further evaluation, the patient, he was tachypneic, he was having a respiratory rate of 40, he was desaturating on room air down to 85%, and ABG was done, which showed severe hypoxemia. Intense oxygen therapy was initiated with high concentration mask, around 15 liters per minute, and antibiotic therapy was initiated with ceftriaxone and doxycycline. Nonetheless, the patient kept on showing signs of deterioration. He was fatigued, he was using accessory muscles, and the hypoxemia was non-responsive to the oxygen therapy. So consequently, the patient, he was electively intubated, and hence he was placed on a mechanical ventilation in order to avoid sudden collapse. The COVID-19 protocol, according to the national guidelines, he was started on a full course of favipiravir, intravenous steroids as well, along with interleukin-6 inhibitors to help get the cytokine storm under control. Patient was showing signs of improvement with time. His oxygen requirements were improving, and the oxygenation setting and the mechanical ventilation was titrated according to his needs. The turning point, it was that the patient, unfortunately, despite multiple attempts to wean him off the ventilator, he failed to be weaned off the ventilator, and he was having poor cognitive status. The patient actually, he was not responding to any kind of stimuli, although he was being off sedation for a significant period of time. And on examination, he had a flaccid paralysis in all 4 limbs. An MRI brain was done to further evaluate his condition, and it showed diffuse bilateral white matter cortical and subcortical lesions that demonstrate T2 flare hyperintense signal, along with diffusion restriction as we can see over here, there's multiple hyperintense lesions in the cortical and in the subcortical area as well. So at that point, it raised the suspicion, could it be microemboli showering to the central nervous system? Could it be some sort of vasculopathy that the patient had developed as a result of COVID-19? So we had a few differentials in mind. So we had to further evaluate the patient. Uh, he underwent a lumbar puncture, which showed an element of elevated protein levels. And we did a nerve conduction study, which showed evidence of critical illness and neuropathy that could be contributing to the overall condition. So our differential diagnosis at that time, we wanted to rule out any sort of embolic stroke, rule out prothrombotic state, and also as part of our differentials, it was CNS vasculitis. So we did an echo which showed no evidence of vegetations as well, and his coagulation panel, including the antiphospholipid antigen, were all normal. Putting the whole picture together, given the fact that the patient was not responding to weaning off ventilation, along with the MRI findings and the fact that he had elevated protein levels on the lumbar puncture, there was no evidence of systemic embolization from the heart, and there was no evidence of any significant coagulopathy, as he had the negative antiphospholipid antigen. So we diagnosed the patient as having CNS vasculitis secondary to COVID-19 infection. So we started the patient on a trial of intravenous immunoglobulins along with the steroid therapy, but unfortunately it had no beneficial outcome at the time. The patient consequently was kept on mechanical ventilation and hence sustained an element of critical care neuropathy and myopathy as well. So a few learning points about this case. So as we all know, this is a new pandemic, and day by day we get to know more aspects of this virus. And as we can see, this virus could have really debilitating effects on the nervous system, as we discussed in this case. The exact mechanism still remains unclear, and it's uncertain whether the COVID-19 directly infects the cerebral vessels causing vasculitis or it's a systemic manifestation of the disease. Furthermore, as I mentioned earlier, that the patient, he wasn't responding to multiple attempts of weaning off mechanical ventilation. So this raised the suspicion that there could be something going on in his central nervous system. MRI finding, as we've seen earlier, it showed extensive cortical and subcortical white matter lesions, and extensive workup was done. And finally, we arrived to the diagnosis of CNS vasculitis, which was basically a diagnosis of exclusion after thromboembolic causes and coagulopathy condition was all excluded. Also, another condition that might have contributed to the overall morbidity of the case is the critical illness neuropathy, as the patient had a prolonged course in the ICU, and he sustained this kind of neuropathy, as shown by the nerve conduction study. So in conclusion, this case supports the fact that the neurological complications from COVID-19 could be actually more debilitating than the respiratory illness itself. Unfortunately, patients could recover with the mechanical support. They could recover from the respiratory illness itself, but to be honest, at times, at occasions, patients would have some sort of CNS insult that could be really devastating as well, and leading to a complicated course. COVID-19, with time, we've seen that there could be several manifestations. It could include the strokes, encephalopathies, and as we discussed in our case study today, CNS vasculitis. This is my reference that I discussed earlier, the Neurological Associations of COVID-19, published in the Lancet Journal of Neurology in 2020, July. I hope you found this case study beneficial, and I hope everyone stays safe in this pandemic. And I would like to thank this organizing committee for allowing me to be part of this lovely webinar and meeting. And I wish everyone to stay safe.